Hello and welcome everyone. Today we'll be discussing when we should be giving parenteral nutrition. First, a case, a critically ill burn patient. It's a young patient with 55% body surface area burns experiencing partial intestinal failure due to persistent diarrhea and volvulus. Despite receiving 200 kilocalories, that is more than the measured energy expenditure of 1470 kilocalories, the patient continued to lose weight, dropping from 53 kgs to 37 kgs. So there was an absorption issue. So a paracetamol test revealed extremely low nutrient absorption, prompting the initiation of parenteral nutrition, after which the weight stabilized. So with the reintroduction of the enteral feeding, there was again a weight loss, which a second paracetamol test showed that there is a continued decreased absorption of the nutrients. So again, a second phase of parenteral nutrition was initiated because of this partial intestinal failure, which finally resulted in weight restoration and wound healing. Although the enteral nutrition was continued, it was not counted towards nutrition absorption but for gut function. So in the final outcome, the total energy delivered reached around 2800 kilocalories, while the energy expenditure was around 1550 kilocalories. The patient ultimately regained weight and was subsequently discharged. So this is one of the cases which highlights the role of parenteral nutrition when it should be given. So this is the data of that patient. The pink is showing the enteral feed, the blue is the parenteral feed. So initially the patient was on enteral feed, but the weight reduced from 50 to 37. The paracetamol test was done, which showed decreased absorption. This is the normal. Now after that, the parenteral nutrition was initiated. Here the patient underwent a surgery for the volvulus and the ischemia, the colonic resection, after which obviously we do start parenteral nutrition. So as per protocol, parenteral nutrition was started, then gradually tapered off. But despite this enteral nutrition which the patient was receiving, the patient continued to lose weight, for which a second paracetamol test was done, which showed that despite no structural abnormality, functionally the intestine was unable to absorb. So parenteral nutrition was initiated, finally resulting in weight gain. So the nutritional need is required when the oral feeding is not possible for several days to maintain the body's composition, support the physical and mental activities, and aid in the therapeutic measures. The choice of enteral or parenteral depends on patient's condition and the GI tract function. The parenteral nutrition was developed in the 1960s for patients with severe malnutrition, particularly those with short bowel syndrome or advanced cancer causing GI failure. The early use of parenteral nutrition, known as hyperalimentation, initially used in patients with severe malnutrition, became more common in the 80s and 90s, especially in the Scandinavian countries because of its ease of use. Until the late 1990s, parenteral nutrition was linked to complications, especially infections attributed to overfeeding, the excessive glucose, and the poor catheter management. Parenteral usage declined due to its associated risk, but increased again after the malnutrition was found in patients when parenteral nutrition was restricted. Recent trials, that is the Calories and Nutria 2, show that enteral and parenteral have equivalent outcomes in terms of complications and results. The gap between the enteral and parenteral has narrowed. The tri-compartment parenteral model bags introduced in the 1990s has simplified handling, reduced the cost, made the parenteral composition more physiological, contributing to improved outcomes. Lipid emulsions with optimal fatty acid combination and the availability of glutamine for critically ill has enhanced the prognosis. The energy needs. How do we know how much is the energy needs? Determining the energy need in ICU patient is difficult due to the lack of measured values and reliance on predictive equations. Both overfeeding and underfeeding are harmful, narrowing down the therapeutic window for optimal care. The energy goals are often based on the hypothesis that the energy expenditure equals the nutritional needs. post the hyperacute phase. Indirect calorimetry is the gold standard for measuring the energy expenditure, but it is often unavailable at most of the common centers. So, new devices make the energy expenditure measurement easier, accurate, and affordable, with newer tools providing results within 5 to 15 minutes compared to the traditional 60 minutes is now done. Continuous ventilator-based devices are used for this, but tend to overestimate the energy expenditure. Now, variability. The energy expenditure can increase due to factors like fever, pain, stress response because of the acute illness, despite overall reduction in the chronic disease. The progress in the ICU therapy has reduced the severity of the hypermetabolism, though it persists for 1 to 2 weeks. The frequency of the measurement. The first energy expenditure should be done between 3 to 5 days after ICU admission, with weekly follow-up for frequent short measurements to capture the metabolic changes. The energy balance. The cumulative energy balance is crucial for the first 10 days and affects the outcome such as hospital stay and mortality. A cumulative energy density of a deficit of around 6,000 kilocalorie is associated with worse outcomes. Now, protein needs. Protein is required for the building of the body. So, we target a protein of around 1.2 to 1.5 gram per kg per day as recommended by several societies. Now, there are some challenges in determining the protein goal because there is no measurable clinical variable which exists to determine the specific individual's protein needs. The blood urea nitrogen level, that is increasing blood urea, may indicate the need to reduce the protein intake. So, regarding the protein deficit, a cumulative protein deficit of 300 grams or consistent delivery less than 75% of the target is linked to poor nutritional outcomes. So, clinical situation requiring parenteral nutrition. Before we go into the indications, let's see why are we even thinking of parenteral nutrition? What are the advantages? So, let's see what are the advantages that the parenteral has over the enteral. Regarding the complications, as we have already discussed, is essentially the same. The physiological reasons that support the GI tract for enteral and to pave way is because it is essentially physiological and it maintains our gut. Regarding the risk of underfeeding, it is larger with the enteral nutrition. Securing a large coverage of nutritional need with enteral is difficult as the patient tolerance is often altered during the first week in the ICU. So, because the patient is unable to tolerate a large amount of enteral feed, there is a very high risk of underfeeding in the enteral. The risk of overfeeding, this is slightly larger in the parenteral, but the nursing effort and the manpower required is significantly less with the parenteral feeding. Diarrhea, again, mainly a complication of the enteral. Costs, use of the parenteral nutrition to cover for the energy expenditure after the day 4 has shown to reduce the hospital costs. So, if we are using the parenteral nutrition strategically in specifically indicated patients, then we can actually reduce the cost despite the higher cost of the parenteral bags. Regarding the immune modulation, the parenteral nutrition and the fatty acids can have a beneficial role. Now, the first indication is complete GI tract failure. GI failure is when the gut cannot absorb even the macronutrients, that is water and electrolytes, requiring intravenous administration to maintain the health. This remains the most important and the primary indication of parenteral nutrition. The common causes are bile ischemia. This can occur due to blood flow obstruction or insufficient blood flow, leading to intestinal damage, possible resection, making the enteral feeding impossible. This was something which happened in the first instance with the burn patient. The GI obstruction, paralytic ileus. The conditions like bowel obstruction, paralytic ileus, and pseudo obstruction often necessitate parenteral nutrition. The next is partial GI failure. This is something which is usually missed. Critically ill patients frequently experience partial GI failure, leading to enteral feeding intolerance in about 60% of the cases. While this usually resolves in 5 to 7 days, inadequate feeding during the time can cause acute malnutrition. In short bowel patients, hyperphagia may partially cover nutritional needs, reducing the requirement of parenteral nutrition. Supplemental or full parenteral should be initiated if the cumulative energy balance reaches negative 4,000 to 6,000 kilocalories. or if the protein deficit exceeds 300 grams, or the delivery is less than 75% of the goal. So in these cases, you should go for parenteral nutrition. The next is vomiting and nausea. This is contraindicates the gastric enteral nutrition because of the aspiration risk. Post-pyloric feeding may be attempted, but parenteral nutrition is needed in severe cases such as hyperemesis gravidarum if the nutritional needs are not met. The next would be diarrhea, uh, defined as more than 3 liquid stools per day, common in ICU patients due to infections, antibiotic malabsorption, and intestinal resection. It leads to dehydration and electrolyte imbalance and increases the risk of bed sore. Persistent diarrhea often results in energy deficit as enteral nutrition is typically discontinued. Parenteral is considered if the diarrhea persists, preventing adequate nutritional absorption. Diarrhea, especially with rapid intestinal transit, causes direct energy loss, making supplemental parenteral nutrition necessary to avoid the malnutrition. Finally, we have malabsorption syndromes. This can result from both functional and physical alteration. Functional alteration is because short bowel mucosa, small bowel mucosa damage, exocrine parenchyme insufficiency, bile production insufficiency. Physical is anatomical abnormality like upper GI resection, high output fistulas. Nutritional absorption issues. In these cases, the nutrition is provided to the upper GI tract, may be partially or completely unabsorbed, and parenteral nutrition becomes a necessity in these cases. So, what are the practical aspects when you need to start a parenteral nutrition? The timing is important. Parenteral or supplemental parenteral should be initiated before the malnutrition sets in. If enteral feeding doesn't cover 60% of your nutritional needs, then please start parenteral feeding. If the cumulative energy deficit is more than 4,000 to 6,000 kilocalorie or the protein deficit is more than 300 grams, start parenteral or supplemental parenteral. Avoid full early parenteral. Full early parenteral should be avoided in the first 3 to 4 days as the body covers around 60% of its energy needs through the endogenous glucose production. Early full parenteral increases the risk of infection and respiratory complications. So consider for parenteral only after you face these problems after 3 to 4 days. If the patient is normal before and suddenly has developed this illness, then the first 3 to 4 days patient can manage with his own endogenous glucose production. The nutritional supplementation, the micro supplements, that is parenteral nutrition solution lack micronutrients for stability reasons. So daily parenteral vitamins and trace elements are required. Vitamins can be mixed with parenteral bag, but trace elements cannot. So you need to know how you can give them. Regarding the peripheral parenteral nutrition, temporary solution is to give peripheral parenteral. It uses diluted substrates, electrolytes and micronutrients to prevent damage to the peripheral veins. It must be temporary and typically last only 3 to 4 days, often after the surgery, to avoid underfeeding and the phlebitis. It is difficult to meet full nutritional needs with peripheral because the volume required will be very large in those cases. Monitoring the parenteral nutrition. The risk of overfeeding must be kept in mind, so keep that in mind and keep monitoring your calories. Blood glucose must be regularly monitored, especially early on due to the potential of insulin resistance, as insulin protocol is used to maintain a blood sugar level of around 6 to 8 millimoles per liter. Blood triglyceride level should be checked twice weekly, as well as the liver function tests. The energy and glucose load should be monitored. High carbon dioxide and weaning failure can occur if the load is high. In such cases, reduce the energy delivery. Refeeding syndrome can happen. Rapid full feeding, especially through parenteral in malnourished patients, increases the risk of refeeding. Blood phosphate level must be closely monitored and electrolytes should be administered. Refeeding syndrome affects 20 to 30% of the population, emphasizing the need for cautious feeding at risk patients. Fluid restriction is an important aspect that must be kept in mind. Critically, patients often face the risk of fluid overload, especially those with renal failure and respiratory issues. In peripheral solutions, the solutions are dilated, so the volume needed will be high, so that must be kept in mind. The central ones are concentrated, so they help in fluid management. The role of RRT in case of chronic renal failure and acute renal failure, RRT can help manage the fluid overload status. The impact on feeding, parenteral nutrition involves additional fluid administration. This must be kept in mind, especially if the patient is having a renal issue. Sometimes the visible water content in parenteral nutrition may lead to decision to reduce feeding in an attempt to avoid fluid overload, potentially leading to underfeeding. So the take-home message is evolving role of parenteral nutrition. The initially restricted role of parenteral nutrition because of hyperglycemia infection is now reduced because the complication rates are similar. So the therapeutic indications are now broader. Improvement in the lipid emulsion and the availability of all-in-one parenteral admix has optimized its safety and effectivity. Recent studies have shown equivalent complication rates. Parenteral is no longer limited to complete GI failure and is now used for cases with insufficient enteral nutrition, malabsorption, and specific nutritional needs which are unmet by the enteral nutrition. So, if the patient comes first 3 to 4 days, if the patient is okay, we don't have any issues. If the patient is malnourished or 3 to 4 days have gone, then check if the oral intake is possible. If it is possible, start oral feed. If no, then consider enteral feed. But re-evaluate the enteral feed for the next 2 to 3 days. If the energy expenditure and the protein expenditure do not meet up, then add parenteral nutrition. And if you cannot give enteral, then consider parenteral. These are some of the indications of parenteral nutrition. You can go through this table. Thank you for your patience.